Ladies and gentlemen, our session will now resume. Please welcome Heather Francis.
Actually, to be fully honest, I'm not Heather Francis, but I have the honor of introducing Heather Francis, so I'm introducing the introducer. Heather is a wonderful person and researcher. She is at University of Indiana. She runs the liver center there. And you'll hear more about some of her work this afternoon, which is fascinating in terms of a cell type that sometimes gets neglected called the mast cell, but you'll hear more about that. Her last movie, I understand, was Oppenheimer, and she's a mother of two, and is also a dog mom. So I'm delighted that Heather is here, and that we can introduce her, and thank you.
Thank you. Thanks so much. So yay for me. I'll just sit here if that's okay to introduce people. And our first speaker is Chris Bowlus, and he's been introduced like 100 times already. And so, Chris, what's the last movie you saw? Barbie. He told me earlier out in the hallway. He's going to update us on some AASLD guidelines. So everybody welcome Chris. And I think that you'll be timed here.
6 minutes?
I think he has 15.
This says, the timer says 6.
Yeah. There we go.
15, okay. So I think many of you may be aware, maybe not, that this past year we published the guidance for primary sclerosing cholangitis and cholangiocarcinoma for the AASLD. So AASLD is the American Association for the Study of Liver Disease, the main sort of professional society for hepatologists in the United States. And every so often we come out with new guidance to help practitioners. And this is a list of the writing group here that came up with this. And I want to spend a little bit of time just talking about the purpose of these guidances and the process so you understand what goes into it. Then I'll hit on a few of the statements we made and why we made these statements that are really more relevant to patients and are relatively new. So first of all, these guidances, they're guidances and guidelines that are developed for a variety of conditions of liver diseases, and they're to share recommended approaches to the diagnostic, therapeutic, and preventive aspects of care. But it's important to recognize that they should not be viewed as standards of care to be followed to the letter. So they are guidance, they're not prescriptive recipes. The process is quite detailed. So there is a practice guideline committee within the AASLD that's responsible for these processes. And then there are what are called special interest groups within AASLD that cover certain diseases. So in the case of PSC, there's the cholestatic and autoimmune liver disease special interest group that this would fall under. And they develop a decision that this is when is a good time to develop a topic for either revising or creating a new guidance or guideline. And then they nominate members to be part of the writing group who will actually do the work of developing the guidance. And that writing group goes under a review process to make sure there's no ethical conflicts. Any kind of professional consultation has to be given up. Any paid sort of consultation fees and things like that have to be given up, so there's no conflict of interest during the writing. And then the development occurs, and first is to develop a scope of work and assign writing assignments to the members of the group. A literature review is done, and then there are drafting of the sections. And eventually there's a draft of the review by the writing group that's then shared with the practice guideline committee, again reviewed, edited, a second draft, a third draft, hopefully approved by the committee, the PGC, which then goes to the AASLD governing board for approval. And then once it's approved there and has been copy edited, it's finally submitted for publication. Now, one of the important aspects of this that's sort of evolving, and really I think our guidance really instituted some of the thoughts of this, is that there's an opportunity for an external review, usually with other professional societies. So if they're writing a guidance on, say, hepatitis C, they may want to get guidance or input from an infectious disease society. But there's no formal process for input from other stakeholders, including patients. Now, this is just a table to show you what the scope of work looked like. You know, we're limited by words. And we went through this process starting in September of 2020, and we didn't get to the final draft till July of 2022. So it's a long, involved process, and we were doing this during the pandemic, and we had lots of Zoom meetings with people, myself on the West Coast of the United States, and another person, 2 people actually in Europe. So 9-hour time differences trying to coordinate. So it is a bit of a task. So anyway, in the end, this is what we came up with in some of the highlights. So the first thing we wanted to do was better define the disease. And one of the aspects that we deal with not uncommonly is this concept of a dominant stricture, which some of you may have heard about. And this is a stricture typically of the main bile duct coming out of the liver. And it was originally defined on ERCP, and it has to have a very specific size and length. But in clinical practice, we use the term dominant stricture for other things, types of strictures. And so there was a feel that there needed to be a different definition for strictures, particularly if they're found on MRIs, which is more commonly used now. And so there is this concept of a high-grade stricture, which again is a structural definition of a stricture, but now seen on MRI and not on ERCP. And then there's what's called a relevant stricture, and that's more of a functional definition. This is a stricture regardless of its measurements, but one that is associated with signs and symptoms of bile duct obstruction. So liver tests go up, the patient has symptoms of pain, fever, jaundice, etc. And so that was one of the more important things. So you might hear your physician talk about these. Most likely they're probably still going to use that term dominant, but at least for us, they mean different things. I think most importantly, and one of the things that came up in the last session is it has to do with diagnosis. And this is sort of the algorithm we came up with for the diagnosis of PSC. And right in the center there in the red box is MRI/MRCP. And nowhere on this slide do you see ERCP. ERCP should not be used for the diagnosis of PSC ever. If there's a question about whether the image is consistent with PSC or not, then it's probably a good idea to go to a center that specializes in PSC and consider a repeat study if the quality is not of high quality, or just wait a year and repeat the test and see if you can get the diagnosis. Now, if the MRC is completely normal, then probably a good idea to go ahead and get the liver biopsy to see if there's small duct PSC or other liver disease that might be there. So liver biopsy is still in there, but only if the MRCP is normal. So if you have a diagnosis of PSC on an MRI, the only reason to get a liver biopsy is if there's concern about an overlap with autoimmune hepatitis or some other condition, but shouldn't be done in routine practice. Now, I just showed this because there are lots of different features we see in PSC besides just the abnormal cholangiograms or other kind of changes of thickening of the bile ducts you can see on other phases. And one of the things we did was really define for our colleagues what we mean by a high quality MRI, MRCP, and what those standards should be. In terms of IBD and PSC, not too much new here. We recommended that in patients that don't have a diagnosis already of IBD, if they have a new diagnosis of PSC, they need to have a colonoscopy with biopsies to see if they have what we call quiescent IBD, that is asymptomatic IBD, which is not infrequent. If a patient does not have IBD, one of the questions is always, well, how often should we go back and look? And this is one of those ones where we really don't have data. And so you can see on that second bullet point, in patients without IBD, subsequent ileocolonoscopy or colonoscopy should be considered at 5-year intervals or whenever symptoms suggestive of IBD occur. And I point out the wording, should be considered, right? It's not you have to do this, you should do this, should be considered. So it's something to think about, but if you definitely have new symptoms, should have a colonoscopy at that time. In terms of prognosis and follow-up, with patients that have small duct PSC, we know they can transition into large duct PSC. And again, this is something not based on a lot of data in terms of how frequently you should monitor, but we felt that a repeat MRI or MRCP every 3 to 5 years would be reasonable in individuals with small duct PSC to see if they transition over to large duct PSC. Of course, if someone has a large change in their liver tests or new symptoms, a shorter interval would be appropriate. But just as routine follow-up, that interval we thought was reasonable. There's more and more data coming out in terms of the use of the transient elastography or FibroScan or some of these other approaches, as well as some of these prognostic models we talked about in terms of the Mayo risk score, and there's many, many more that we discuss in the guidance in terms of which population. There's a specific one for pediatric group of patients, and they're quite helpful, I think, in understanding what the prognosis is, but we have to be careful in terms of the individual. But they can be considered to give us an idea of what someone's sort of, outlook is or risk is for problems in the future. So in terms of staging the disease, transient elastography or MR elastography are really what we should probably be using in the clinic if we want to know what stages someone is at or how they're progressing. We really want to avoid doing a liver biopsy. We don't recommend this in terms of fibrosis staging, at least in clinical practice. Now, clinical trials is a different matter, but in clinical practice, we should not be doing liver biopsies just to see if someone's disease is progressing. In terms of surveillance for cholangiocarcinoma, one of the things that came out after we did our guidance was this study. It was a prospective study in Sweden where they took over 500 patients and followed them over 5 years with annual MRIs and the cancer marker CA19-9. And they only found about 13 cholangiocarcinomas and 5 gallbladder cancers and 1 liver cancer called hepatocellular carcinoma. And their conclusion was there's little benefit of all this surveillance that we're doing. Now, if you look retrospectively, you see that people, and those are the figures on the right, people that undergo surveillance tend to do better than people that didn't do surveillance. So we have some conflicting data, and we based our guidance on those older studies we have. But I think this is an area we definitely want more data to make more informed decisions or recommendations on. But currently, we recommended that surveillance for cholangiocarcinoma and gallbladder cancer should be performed annually with abdominal imaging, and we think it should be preferably done with MRI and MRCP, and with or without the CA19-9. The CA19-9 has some real limitations, so we kind of left that as a plus minus. It's not recommended, though, in patients that are under the age of 18 because the risk of cholangiocarcinoma is so low in that group, or in patients with small duct PSC, again, because the risk of cholangiocarcinoma is so low in those two groups. It's unlikely to be of any benefit. And then the other cancer risk is the colon cancer, and no change here. If you have IBD and PSC, you're at high risk of colon cancer, and you should start having annual colonoscopies or every 2-year colonoscopies, even at the age of 15, because we see an increased risk even at that young age. There are other management recommendations we made in terms of patients with IBD, post-transplant, assessments of nutrition and bone density for patients, and then liver transplant considerations in terms of both who should be transplanted and in terms of looking for recurrence of PSC after the transplant. And I'm going to run out of time because I only have less than 3 minutes, and now I'm getting into the real tough questions here that we had to address. And that has to do with medical treatment. And number one we said was all patients with PSC should be considered for participation in clinical trials, something we talked about in the last session. Now, the other things we had to discuss in terms of treatments, number one was ursodiol. In the previous guidance in 2010, they recommended against the use of ursodiol. And that was because it was just after a large clinical trial was done in the United States with 150 patients treated for 5 years, either with placebo or a very high dose of urso, and the people that got the high dose of urso actually did worse. There's also a Scandinavian study that used a lower dose that showed no benefit in terms of either reaching transplantation or dying between a lower dose of urso and placebo. But there was a concern there about using urso. Since then, there's been some other data to suggest that if you reduce the alkaline phosphatase in some of these trials, those patients did better than those that didn't. We know URSO is safe. It's demonstrated that it reduces alkaline phosphatase in pretty much all the randomized controlled trials. Another study showed that if you stop URSO, you can get worsening of symptoms, liver tests, and the Mayo risk score. So based on that, we went a little bit out there and said, in someone that's got persistently elevated alkaline phosphatase, or in kids, GGT, this ursodiol at this lower dose can be considered. Again, not saying it should be done, but can be considered and continued if there's a meaningful reduction or normalization of the alkaline phosphatase and symptoms improve with a year of treatment. Now, probably the most divisive topic within the PSC community has to do with oral vancomycin. And this is one of the things that we really struggle with. And I have to say, I had dinner last night with a dad whose experience, or son's experience with oral vancomycin is pretty striking. His son started taking oral vancomycin, his IBD got better, his liver tests are now normal. And I think we have lots of individual experiences where there's patients that take the medication and feel that there is improvement in their disease. The problem we have is we can't use that as data to make recommendations. And if we look at the data that's available, it's really limited on oral vancomycin. So we talked about randomized controlled trials. There was a randomized trial of 29 patients treated with oral vancomycin or placebo for 12 weeks and reported improvement in the Mayo risk score, which includes age, bilirubin, albumin, AST, and variceal bleeding. I'm not sure how they got improvement in Mayo risk score in a meaningful way in 12 weeks with oral vancomycin when age, variceal bleeding don't really change, bilirubin's hard to change. So I'm a little skeptical, but it's a small study, short-term duration, even if the results are correct. There have been some open label trials. There's one from the Mayo Clinic where a small number of patients, again, treated with either a low dose or high dose of oral vancomycin for 12 weeks, suggested that there was an improvement in alkaline phosphatase. And then there's this open label trial of 30 patients enrolled in the trial, and 29 patients reported along with them that were treated outside the protocol. Importantly, almost half of them had small duct PSC, and also included patients that had previously been treated with oral vancomycin. So these are all pieces of evidence, but they are not of the quality, number of patients, length of therapy that would make us feel comfortable that oral vancomycin is, number one, effective. Number two, the routine use of antibiotics has the risk of developing resistance. We all are very careful in the use of antibiotics because we know that chronic use and repeated use, we can develop resistance with vancomycin. The concern is with vancomycin-resistant enterococcus. Now, typically, oral vancomycin is only given for a short duration for the treatment of C. diff colitis, and there's some controversy in the field, the infectious disease field there, whether it enhances or increases the risk of developing this vancomycin-resistant enterococcus when it's used in short term. And in this scenario where it's being used long term, after we wrote this guidance statement, there was a paper that came out from India that reported on 7 patients treated for at least 6 months, and they were not able to detect VRE in any of those patients. So there's some bit of evidence there, but again, relatively limited in terms of numbers or even time. So that is the totality of evidence that we have to look at for oral vancomycin. And so the statement we came out was, currently there is insufficient evidence to recommend the use of oral vancomycin for the treatment of PSC. That's what we came to. Thank you for your time. I want to just also point out all the people that were involved in this process. Myself and David Assis were the co-chairs of the group. The list of individuals here include expertise in radiology, pediatrics, surgery, oncology, from wide, different, varied backgrounds, and was just a really amazing process. And I hope you have the time to really look at that entire guidance if you have any questions. Thank you very much.
Thanks, so much. Our next speaker is Gideon Hirschfield, who's also been introduced here multiple times. He's a great supporter of PSC Partners and is doing some fantastic work at the University of Toronto. And he's going to talk about what's new on the horizon for PSC treatments that then you'll get to write a new guideline about.
So thanks, Heather. Thanks, everyone. So what I've got is a series of slides which really, I'd rather you focus on what I said, and the slides are really my anchor points to remind me what to say. The second thing is, Ricky, I will look at the clock, but actually what I'm going to do is I'm watching Don. If Don falls asleep, then I know I've spoken too much, okay? So stay awake. Okay, because this is really exciting, because it's what's really exciting about clinical trials in PSC is the commitment to making new drugs. What's also really exciting is that we know that when you take part in a clinical study, you don't usually derive much individual benefit, but the community does. And despite the fact that we have a long list of trials that haven't maybe hit the mark we want, trust me when I say we actually learn and we make a better study the next time, because it's an iterative process. And the other thing I would just say, just generally, is I've seen really positive treatment effects for people's well-being by taking part in research and taking part in clinical trials in particular. Huge amount of uncertainty with PSC. Doing something positive and signing the form to be part of a study is affirmative and is an opportunity for you owning some of the journey. So our care, dovetailed on to what Chris just said about AASLD guidance, just generally is to get you a good diagnosis, personalize the therapy to you, prevent end-stage liver disease, symptoms management, challenge inequity, and finally, champion innovation and excellence, which is what you've been hearing about for the last day and a half. The disease is a real challenge. So this is, a picture of what it looks like from a patient and a clinician perspective of what I'm trying to treat. You'll see that on the right is the sort of karma, okay, just to keep you calm, so when the stress of living with PSC and the complications. On the other side, you see your ERCP, you see your colonoscopy, you see your esophageal bands, you see your spyglass cholangioscopy as they're looking at your stricture. You see the liver imaging, which shows something sinister and needs investigation, et cetera, okay? We're trying to prevent that because it's a disease that challenges us all, and in its largest sense, untreated, even with URSO, plus or minus Vanco, there's a really high rate of needing liver transplantation to get you to old age. To really get our clinical trials right, actually what's more important than some of the molecules is getting the right patients in the studies. This is just a study we did with Toronto. We also got some great help from the Mayo Clinic, just to try and work out which of you in this room are likely in the next 10 years to have an event. So if your bilirubin stays completely normal and your FibroScan stays less than 10, actually the next 10 years, statistically at least, are good. Whereas if your bilirubin's on the rise and your FibroScan is on 10 and above, then that's a group of patients who are progressing. It helps me when I think about how to develop the trials as to who to put into the studies. And this is the data for the FibroScan. And that's why we're learning from every time you come to clinic and looking at your blood test and deciding your suitability to take part in those studies and to make them more successful. But it's really hard because we rely on ALK phos. We would like to rely on other things. And all the studies I'll show you will really be readouts of alkaline phosphatase, that marker of biliary injury. You might say, look at this graph of alkaline phosphatase. It's flat. It hasn't moved. That drug is failed. Put it in the bin. It will never be used for PSC again. Okay? That might be a fair interpretation. You might also say, wow, look at that alkaline phosphatase. It went from that down to that. This is a winner. I'm going to go to phase 3, ask my patients to do liver biopsies every week, and it's done, okay? Or you might say the ALK phos is not the right test, okay? But we haven't yet developed a better test, because actually both of those patients, that's the same patient, just with different frames, and the patient was getting placebo, okay? So it's a very difficult biomarker to use, okay? It's very important. It is meaningful, but it's very difficult to use. So when we look at trial results, what we call negative may not be negative, and we are also cognizant that one study may not give us what else we want, but maybe we can bring that drug back later on. And really importantly, we have two categories of trials. We have trials that are designed to stop you needing a liver transplant, at least in the long term, and we have trials that are going to focus on your symptoms. And the drugs that we choose may be very different, deliberately, okay? And you've already heard yesterday from some of the itch study companies that are out there doing some really innovative work. We haven't yet started trials on fatigue because it'd be too hard, I think, but pruritus in particular is a really important area for drug discovery. So this is the group of drugs that are being tried at the moment, with everything else being much more early stage, to help you live with your PSC better. They are largely drugs that we have developed in primary biliary cholangitis successfully, which reduce inflammation, reduce cholestasis, which is the response to blockage, and we think therefore will reduce scarring. Or they focus very specifically on scarring of your bile ducts or scarring of your liver. Before I delve into those, we did hear, actually, Josh mentioned, every patient with IBD, there's a sequence of different biologics that we can try, okay? So we have been looking retrospectively at people who've got new drugs for their IBD to see whether or not it helps, okay? These are patients who got vedolizumab, Entyvio, for their IBD, and they have PSC, and we looked at, Kate Lynch, and she's now in Australia, looked at their alkaline phosphatase over time, to see whether there was any signal that the drugs were making them better, okay? What you can see is that 20% the ALK phos went up, 20% the ALK phos went down, and 40% the ALK phos stayed the same, okay? So to the shrewd person in the room, it doesn't make a difference. Just to prove a point though, the doctors that look after you are very, very nice, I think, okay? And when they wrote the abstract for the paper, they focused on the 20% where the ALK phos dropped, okay? They didn't focus on the 80% where nothing changed. So in our hearts, we do want drugs to work, and that will bring on the controversies about Urso and Vanco. We've got this sort of tangent between the data and between what we'd like to believe and our emotions, okay? This trial is ongoing. It's by a company called Pliant. You would have noticed your ID badges are all sponsored, I think. I've got Pliant. Is it Pliant or Mirum? Yes, Pliant. Okay, so this is an oral antifibrotic drug. This drug, forget the exact details, goes in and targets a very, very specific molecule, which is like a lock and a key. And when that lock and the key come together, it generates molecules, one called TGF-beta, which cause fibrosis. And this drug's being developed for lung fibrosis and liver fibrosis, and there's a very big study now going on at phase 2 across US, Canada, and the world, and we'll find out in the next 12 to 18 months whether or not this drug affects fibrosis. And so this drug, we won't be interested in whether it drops alkaline phosphatase, we'll be interested to see whether it drops markers of scarring. Okay, what about making a better Urso? Urso, controversial. Everyone knows my opinion, it doesn't do anything, okay? The companies that have been developing Urso have then made new molecules of Urso, which are nothing really to do with Urso, but have got a chemical moiety on the side. And what that does when you take it is it pumps bicarbonate, okay? Bicarbonate, alkali, it pumps bicarbonate into your bile ducts, so it soothes your bile ducts. And in phase 2 clinical trials, there was a modest but clear effect on alkaline phosphatase, the marker of biliary injury. So there's now a European-only phase 3 clinical trial where the endpoint will be patients getting Urso, and they'll have liver biopsies and they'll have blood tests, and they'll be followed up for many years, and within, again, another 12 to 24 months, we'll get some signal whether it works. This was an interesting molecule that we did a clinical trial on NGM282. The reason I highlight it is because it's a different approach to reducing cholestasis, but also what we learned during this study was, do we have the right endpoint? ALK phos is variable, and it only measures one compartment of the injury. There's liver cell inflammation, there's bile duct inflammation, there's fibrosis, okay? So the details, again, are not relevant, but patients either got placebo or drug, okay? Look at the ALK phos. The ALK phos is in the top left. It did not budge, okay? But what did budge was your ALT and your AST. So one marker of injury in the compartments that cause PSC, the bile duct marker, didn't move. Another marker did, okay? So maybe this drug is picking off some of the inflammation, but not necessarily tackling one of the other aspects in terms of the cholestasis. What was more interesting is this drug has been developed for fatty liver and has been developed for PSC. And in both the development programs for fatty liver and PSC, markers of liver fibrosis, you heard about those this morning, ELF test, and there are other assays which are more research called procollagen, which literally measures collagen, which is the fibrosis being laid down. It measures it in your blood. Both the ELF test and the procollagen over the short duration study dropped when this drug was given compared to placebo. So we had real little hints that there were effects on inflammation and effects on scarring. And of course, what was interesting is we actually saw the same in patients who got fatty liver who got this drug. So, this just shows you the primary endpoint wasn't met. We didn't reduce alkaline phosphatase. But buried within the data set were signals that the drug is doing something, and we need to keep that in our minds as we focus. Obeticholic acid was the first new therapy for PBC in 2016. So until then, there had just been ursodeoxycholic acid. That is our dream, that we can do the same for PSC. Okay, we demonstrated that we could do clinical trials in a rare disease, that we could persuade the agency that they were safe and effective, and patients could receive them in the community. Naturally, obeticholic acid was then tried in primary sclerosing cholangitis. This was a small study. Chris Cowdley's already gone home, I think, but he led the study. There were some signals of efficacy, but there were also some downsides as regards itch. Another company, because our chemists are really clever people, said, well, you can make these drugs that we call FXR agonists either by making them look like the body. So obeticholic acid is what's known as a semi-synthetic FXR ligand. It looks similar to what the ligand is in the body. What other companies did is they made their own molecule from basic chemistry up. So it just basically does the action on the target that we want. And this was the Gilead drug, okay? And many of you may have been in this clinical trial. In the early phase studies, there was an effect on alkaline phosphatase, a signal, okay? Biochemistry then, over a long time, like I showed you, actually started to settle, and there was no signal. And then when we went to AASLD in the big European meeting, okay, we saw Michael Trauner actually present the final results. And I know all of you, when you're in clinical trials, they always ask me, when will I find out? What was I on? Were we on placebo? What was the answer? So this was the big study, which was international. Hundreds of patients took part, okay, placebo-controlled. You have to have the placebo. Somebody has to get placebo to see whether the drug is working, okay? This is what you look like. This is what we call the baseline table, table 1 of when we write a manuscript. It just describes who you are, what your blood tests were, what your gender is, whether you've got inflammatory bowel disease, how much scarring you had, okay? Unfortunately, it wasn't a clear win. Okay, when looking at liver scarring under the microscope from liver biopsies, drug versus placebo, there's no difference. Okay, so disappointing, but still an incremental step because we learned more. Okay, and the blood test didn't change either. So although in the early phase study, phase 2, we saw some effect, in the longer study, more representative, more patients, more centers, the blood test didn't budge. Okay, does this mean that cilofexor had no effect? Well, that would be an unfair conclusion. Does it mean that it's the next drug for PSC? Probably not. Okay. Other ways of developing new drugs are to take what we have, ursodeoxycholic acid, and then to take things that are also around. So in China, there's a compound called berberine that's been used for diabetes, insulin resistance, and fatty liver. And High Tide are developing this drug for fatty liver, but have also looked at it in PSC. When you take HTD 1801, it dissolves inside you and you get some urso and you get some berberine. And we did a study, and again, Chris was the first author, and I was involved, and other people in the room actually were involved as well. There was a small effect. So maybe this will be another way of improving that toxic bile that's causing you harm. Chris did a really good job of discussing the challenges with vancomycin. What I want to just challenge you is we have a one-size-fits-all model for clinical trials. We want you to take part. The studies are very, very traditional, okay? Let's just imagine a world where there's 100 patients with PSC and 2 of them take vanco, and in those 2 people, they're cured. But in 98, vancomycin doesn't do anything. In our current model of clinical trials, we would not be able to pick that up. It would be impossible to pick up that small subgroup who get an amazing benefit versus the larger cohort who doesn't get a benefit. So you can see we need a many ways to develop new drugs and many ways to have clinical trials, okay? Some of them traditional, some of them less traditional. Some rare diseases, what they do is N of 1 studies, where the patient is their own control, okay? Because the disease is so rare, you can't do placebo. So hopefully as a community, that's where we'll head. Biopsies, we've talked about, really challenging. When you biopsy a patient many, many times, you discover that a third of you get worse, a third of you stay the same, and a third of you get better, whether you get placebo or drug, okay? So even a biopsy, which is invasive, has limitations. What else is on the horizon? I already told you about IBAT inhibitors for itch. Really exciting because they've been licensed now in pediatric liver disease. You'll know that we've got what's known as fibrates or PPARs in PBC. So people are now trying those drugs in PSC because we've tried and seen success in PBC. So that's on the horizon as well. This is a very quick slide to tell you how hard it is, as an investigator. This is a study that I did in Birmingham, okay, where we took a drug that blocks a marker or an enzyme that causes fibrosis. We got, a number of patients to take this completely experimental drug as an infusion. It definitely did what it said on the tin. The marker, what we were targeting, a molecule called VAP1, went right down. But unfortunately, the blood test didn't change. Now, the trial is not a success, but we could only get funding for 3 months. If I was wanting to develop a drug for scarring, I probably need to test it for at least 12 to 18 months. So really tough, okay? Negative, but informative. So I did a quick search on clinicaltrials.gov just to make sure, again, you all know how active the field is. IBAT inhibitors in PSC, elafibranor in PSC, simvastatin is being tried in PSC in Scandinavia, okay? Mirum, another IBAT inhibitor for itch, vancomycin, there are lots of clinical trials trying to answer it, and chemomab have got an anti-CCL24, so something which soothes your bile ducts. So there's a lot going on, and I'm sure there'll be more. So, within my 5 points for PSC care, which I realize have my own bias, you'll see at the bottom, having diagnosed you compassionately and carefully, having given you your choices about what you do about URSO, what you do about Vanco, when do you need a transplant, helping you with your symptoms, I hope, smartly surveying you for cancer. But every time I see you and every time my fellow sees you, we think trials. And we think, if we can develop drugs for PBC, despite it being very distinct in terms of bile duct disease, we can do that for PSC. And we'll only do that if we get more and more patients coming to specialist centers, being given the choice to take part. And studies go all the way from observational cohorts like the registry, like the WIND study, all the way to sort of drug trials. And if we do that, I am confident that in 10 years' time, it will look different. Thank you.
Gideon, that's fantastic. We'll move on to our next speaker, who is Dr. Jennifer Lai. She's a practicing general transplant hepatologist and a board-certified physician nutrition specialist who's going to talk to us about nutrition in PSC. And she is from the University of California, UCSF, San Francisco.
Great, thank you very much. It's such a pleasure to be here to talk about one of my favorite topics, which is nutrition in PSC. I am a hepatologist and a physician nutrition specialist, as you just heard, but I am not necessarily your physician nutrition specialist, except for a few of my dear patients who are in the audience. So hi, thanks for coming. And so just there's my disclosure that that all nutrition advice really needs to be personalized to you. So I've had the honor and privilege of caring for patients with PSC for over 15 years now. And undoubtedly, the single most common question that I get asked is, what should I eat to protect my liver? Does that question sound familiar to any of you? Yeah, I'm getting some head nods. And I'm curious if the answer from your hepatologist or gastroenterologist or primary care doctor has been the same as, unfortunately, what I've had to tell my patients, which is there are no known foods that help in PSC. I'm getting some nods that this sounds very familiar. And although it is technically true, I've looked at the literature. There are no randomized clinical trials looking at specific foods on the effect of PSC. As a clinician, as a healer, I have been very frustrated by the answer that I've had to tell my patients. And so over the last 5 years in my journey of learning about nutrition for liver disease, I have actually, and focusing on this topic, I've actually realized that we need to step back in figuring out what to eat, and actually perhaps the better question is how to eat to protect my liver. Let me explain. Your liver is being attacked by this disease process of PSC. It's inflammatory and it's causing fibrosis within the liver. But outside, there are other external forces that can also attack the liver. These are excess caloric intake and excess sugar intake. These can further attack the liver by depositing fat, which can also be inflammatory to your liver cells. Now, in order for us to better understand this, I want to take us through a maybe 2-minute journey into mini medical school on the topic of liver lipidology, that is the study of fat regulation by the liver. There are 3 main mechanisms by which the liver regulates fat. The first is that when the liver sees excess calories, so this is more than what the liver can store as instant energy, and more than what the body needs as instant energy in the form of glucose, those excess calories get converted into fatty acids within the liver, and fatty acids in the liver and ultimately the body can lead to obesity. That increases circulating fatty acids, and increased fatty acids in the liver and in the circulation will stimulate the liver to create liver as a storage within the liver. So this is a process called de novo lipogenesis, and these liver droplets get deposited and squeezed out of the liver cells and sit in the liver. You can see it on your FibroScan or on your MRI. And this process, contrary to popular belief, is not stimulated by fat in your diet. It is stimulated by sugar. And in fact, perhaps the most potent stimulus is fructose, which is the instant sugar that is frequently found in ultra-processed foods, which we're going to talk about a little bit later. And lastly, when the liver sees excess fatty acids, this gets packaged into triglycerides as well as VLDL, which is a more benign, goes into the tissues and the membranes, but the triglycerides then further get deposited into your body fat and your liver, and this leads to obesity and worsens the whole process. And so now hopefully you can see that how excess caloric intake and excess sugar will lead to fat deposition, which can irritate the liver cells even more so than the PSC process itself. And that healthier eating habits can help to provide this protective shield for your liver that is already being harmed by the PSC. And we can sort of take away these factors and reduce the likelihood of fat and inflammation from healthy eating. And so today I'm going to offer you just 3 of the many strategies I love to provide my patients for healthier eating habits. And the first one is to start trying to shift from this concept of feeling physically full to satiated. So I think when we say, oh, we're so full, it's so frequently accompanied by this physical sensation, your hands on your belly, everyone leans back because their stomach is so big, they start, feeling their waistband. There's so much physicality to fullness. But I want you to start thinking about fullness as actually a mental state, a psychological state of satiation, because there's so much more that goes into satiation. These are things of the look of the food, how beautiful it is, the smell of the food. When was the last time you really noticed the smell of your bread roll, for example? Obviously a piece of meat, that's very, very, there's a lot of aroma there, but think about the smell of all the foods that you eat. Of course, the taste can be very satiating. The eating environment, yesterday at the dinner tables, having great conversation with like-minded people, sharing around that really contributes contributed to my satiation, and also an appreciation for what went into preparing that food, picking that food, transporting that food. And this is really the philosophy behind mindful eating. Mindful eating is the process of really taking in all of these factors and having a great appreciation for each bite of food that you take in. And one of the great advantages of mindful eating is that it also forces you to slow down. There is actually a randomized clinical trial out there that looked at randomized individuals to a slow pattern of eating or a fast pattern of eating, just a single meal, 600 calories, 6 minutes versus 24 minutes. That was the normal eating group was 6 minutes, and sort of reflect upon how fast you ate breakfast this morning. It was probably closer to 6 minutes than it was to 24 minutes. And what they found actually was that the individuals randomized to the slow eating group, the 24-minute group, actually had higher levels of the satiation hormones in your body. So there were biologic effects of slowing down. And then it translated into behaviors. They ate 25% fewer calories with their next meal, and they reported feeling fuller for a longer period of time after that meal. Some strategies to help you increase sort of the satiation and to slow down is to start your meal with a glass of water before you start eating, because then you're already starting to prime your stomach, and some of the satiation hormones can get started early on just with a 0-calorie glass of water. Put your utensil down between bites. Don't eat while you're on the go, not in the car, not when you're walking, but only when you're sitting down at a table. And of course, this process of mindful eating that I just spoke about. The second strategy I want to talk about is shifting your diet from predominantly ultra-processed to whole. And I say predominantly because actually studies have shown that the average US adult eats about 60% of their calories from ultra-processed foods. Ultra-processed foods are formally defined as industrial formulations, typically with 5 or more and usually many ingredients. And they include food substances. There's the definition of food substances. I can't even pronounce some of them. Commonly used in culinary preparations whose purpose is to imitate sensorial qualities of unprocessed or minimally processed foods. These are like colorants, flavorings, and the non-nutritive sweeteners. This concept of ultra-processed foods sits on a spectrum of food processing, and I really want to emphasize this word ultra and try to incorporate ultra into your language, because quite honestly, most food is actually processed. It's the ultra-processed foods I want you to be hyper aware about. The spectrum of food processing is it has been classified under the NOVA classification scale, which is internationally endorsed. And I just told you about the ultra-processed foods, which can most easily be identified as something wrapped in plastic and contains at least one ingredient that you would not recognize in your own kitchen, or we can even expand it to a chef's kitchen. You know, I don't think a chef has hydrolyzed protein in their kitchen cabinet. And these are, we all know them, pretty commonly: cold cuts, soft drinks, ice cream, cereal, hot dogs. If we shift towards a slightly healthier type of processing, or a healthier type of processing, these are just processed foods, industrial products made using preservation methods such as canning, bottling, and fermentation. This is like bread, fermented cheeses, jam, tofu. And then we move down in the processing, and these are processed culinary foods. These are foods that need to be extracted in order to sort of season your food. And think about something like oil or salt or even sugar. Remember I said that virtually all food is actually processed. So you don't want to avoid processed foods. You want to avoid the ultra-processed foods. And then, of course, we move down to unprocessed or minimally processed foods. And these are the foods that you can actually recognize on the table as having been sort of picked from the ground, or you know exactly where it came from, with minimal processing, minimal steps from the farm to the table. And as you can imagine, the more that we can eat on the right side of this graph and less on the left side of the graph, the more we can provide our liver with this protective covering and preventative foundation and strategy for good health. The reason why ultra-processed foods are so particularly bad for our liver is because they contain a lot of added sugars, and they're a way too easy way for us to bombard our liver with too much sugar. So in a survey of nearly 10,000 adults from the NHANES survey about a decade ago, what this survey found when they actually analyzed the amount of sugar that was being taken in by the average US adult, 4% of the calories came from sugar from minimally processed foods, processed culinary foods, or just sort of all the processed foods combined, so the right 3 boxes in that NOVA classification, but 21% of the added sugars came from ultra-processed foods, 5 times as much. So think about the benefit that you can offer your liver if you shift from eating ultra-processed foods to choosing a minimally or whole food. How sort of magically you can reduce and automatically reduce the amount of excess sugar that you're taking in. So what are some strategies that we can use to reduce our added sugar and ultra-processed food intake? Well, the first is to eat from a bowl, not from a bag. And I'm sure some of you are thinking, well, I can sort of open a bag of Cheetos and put it into a bowl, and that might count too. And truthfully, yes, that actually I think is a better strategy than eating a whole jumbo bag of Cheetos. Maybe you just eat a little bit less. The second is shop the perimeter of the market. Given the distribution, the food distribution chain, the fresh stuff has to be at the edges because it's coming from the warehouse behind, and the shelf stable, the preserved stuff, the stuff in bags, the stuff that contains at least one ingredient that is not found in a culinary kitchen is actually in the middle. So try to shop the perimeter, fill your grocery cart up with the fresh stuff first. Ask yourself, would my great-grandmother recognize this food? Mine definitely wouldn't, but quite honestly, you might start with, can I recognize this food? I don't know where this one came from. You know, I really don't know, although I have had some cheese puffs and they are really good. Okay, the last piece of advice is to increase your amount of fiber intake. So what is dietary fiber? I've really been geeking out on fiber, so I'm going to try to do this in a minute and 15 seconds. But dietary fiber is a carbohydrate that the body can't digest. It actually is a bunch of sugars linked together, but with certain bonds that our bodies don't have human enzymes to digest them, so they actually exit the body undigested. There are 2 types of fiber. The one is insoluble fiber. This is the fiber that does not dissolve in water. It promotes regularity. It can help with managing constipation and is very commonly called roughage. Soluble fiber is the kind that dissolves in water. It's gel-like, it's viscous. It can actually help with both diarrhea and constipation. And this is the one that is broken down into short-chain fatty acids. If you guys have heard all the health benefits of short-chain fatty acids, by the mucosal bacteria, by the microbiome, and actually can help your gut form a really healthy mucosal gut immune system and feed the gut cells to make them really healthy. There are many benefits of fiber. Foster a healthy gut microbiome, regulates blood sugar, helps you feel fuller and more satiated, and is associated with a lower risk of colon cancer. Very, very important, particularly in patients with PSC. Here is the recommended daily fiber intake. I'm just going to let you quickly figure out which box you are. It's somewhere between 20 and 30 grams, and 40 grams. The vast majority of people are in the 10 to 20 range, so even if you can get above 20, all the better. And those are the 3 strategies that I am offering you today in order to help play a very active role in providing protection for your liver with PSC through the way that you eat. Thank you very much.
So much, Jennifer. So we'll move on for our last presentation, and our last speaker is Cara Mack, who is a pediatric gastroenterologist and a pediatric transplant hepatologist at Children's Wisconsin and the Medical College of Wisconsin. And today she is going to speak to us about the Children Network, the prospective observational study of PSC in children.
All right, thanks, Heather, and yeah, for inviting us to talk about our prospective observational study of PSC in children. So this is a study that's been running for a little over a year. The information here is available through clinicaltrials.gov, and it's a prospective longitudinal study in children. We're going to be following multiple parameters that I'll go over in detail for 10 years. It's sponsored through the Childhood Liver Disease Research Network. They're the group running the study, and that is supported by the NIH. The inclusion criteria is simple. It's age 2 years through age 25, and we are taking children, young adults in their early 20s, even if they can only participate for a few years. It entails large duct or small duct disease, and we are enrolling both newly diagnosed patients as well as those who are previously diagnosed. There is a long list of exclusion criteria. The exclusion criteria point towards a diagnosis other than primary sclerosing cholangitis, so most of these would relate to actually that the diagnosis is a secondary cause. Shown here are the sites that are currently enrolling patients throughout the United States, and in Toronto, there are currently 13 sites. And in 2024, there will be a renewal of this grant, and they are opening it up for additional sites to apply to. So the enrollment began in December of 2021. We've enrolled approximately 100 children so far, and we plan to enroll up to 700 over 10 years. I want to go through the 4 aims that we have for this study so you understand what your child would be participating in. The first is to clearly characterize the different phenotypes of PSC in order to understand how the following parameters would alter the progression of fibrosis as well as clinical outcomes. We'll be looking at how the intestinal inflammation of IBD impacts the PSC in children and be monitoring clinical activity of their IBD with each visit. We're going to be looking at the hepatic inflammation associated with autoimmune hepatitis, the overlap syndrome that children often have. Up to 30–40% of our children are diagnosed with both autoimmune hepatitis and PSC. And one of the goals of this study is really to answer the question, is that inflammation that we're seeing on biopsy that we're calling autoimmune hepatitis, is it truly typical autoimmune hepatitis, or is it more simply inflammation associated with the PSC? And the reason the frequency of inflammation and autoimmune hepatitis is so high in children with PSC is that we're seeing an earlier stage of the disease. So we should be able to tease that out with this study because we're going to have access to all liver biopsy tissue that were performed for clinical reasons for these children. We'll be looking at the role of the medicines on outcome, and then as well the incidence of recurrent bacterial cholangitis in children and the impact that has on outcome. The second aim is to look at the quality of life. I'm embarrassed to say there's essentially no study that looks at how PSC impacts the quality of life in children, no large study. So we're going to systematically assess the burden of PSC on the quality of life in children through assessment of health-related quality of life surveys, as well as surveys related to itch, fatigue, and sleep. In addition, in our teenagers, we're going to look at the adult PSC, patient-reported outcome tool that is currently validated in adults and see how well that resembles how the children are feeling. The third aim is to look at imaging, and this is a fairly aggressive aim where we're going to assess the accuracy of various imaging modalities that measure fibrosis, specifically the FibroScan as well as MR elastography, and imaging modalities that measure large duct injury. That would include measures of a basic MRCP, but also we've partnered with Prospective to look at a new research tool, MRCP Plus, that can quantify the amount of stricturing and dilations. And again, we want to figure out, can we see how well these imaging studies predict severity and progression of PSC. Some of the questions we'll be able to answer with this aim: do the imaging findings correlate with clinical outcomes? Can the imaging findings predict the rate of progression of disease? And we're going to be following these kids every single year for 10 years, so we should be able to answer that. And do the imaging findings correlate with other prognostic biomarkers? This is an example of the MRCP Plus technology that we'll be using. On the left is a picture of a normal biliary tree, and as the ducts are smaller, the color goes to the more red. So this is a normal biliary tree with the smaller ducts inside the liver being red, and then as the ducts get bigger, the color reflecting the diameter becomes more yellow. On the right is a PSC patient. We will be doing baseline MRCP plus as well as 1 and 5 year MRCP plus analyses. And this example shows you that at baseline, you've got some biliary dilation based on blue, a few strictures based on red, and that a year in follow-up, there's an increase where you can quantify the number of strictures. So this is a research tool that we want to study the effectiveness of it in children. And then finally, aim 4 is to create a robust repository of serum, plasma, peripheral blood mononuclear cells, and those are the white cells in your bloodstream, liver biopsy tissue that's been obtained for clinical purposes, DNA, as well as stool. And this is for future research studies, and it's really important if you're doing an observational study where you're collecting all this information over time related to how the patient's doing, what are their labs. You need to have some biospecimens ready to do mechanistic studies to predict outcome, biomarker discovery, et cetera. So a few examples of that: we plan on using the plasma for the discovery of biomarkers that may predict severity or progression. With the white cells that we'll have in the freezer and the liver tissue, we can do studies on the mechanism of biliary injury and fibrosis. With the DNA, we plan on looking at our children who have small duct only PSC, much higher rate in children again compared to adults. Up to 30% of our kids will only have small duct PSC, not large duct. So is that a unique entity? Could there be a genetic predisposition to that small duct only PSC? And we'll be able to figure that out through this study. And then finally, stool is going to be collected to look at the microbiome that you've all heard about is so important in the pathogenesis of disease. Here's a snapshot of the visits that your child would go through. The baseline visit is the most important visit where we're going to collect all of the information of those 4 aims that I just discussed. We will be doing targeted history, both related to liver PSC diagnosis and IBD diagnosis, the medications, as well as targeted liver events such as cholangitis or portal hypertension with a GI bleed. And then if you're newly diagnosed, you'll have a 3-month follow-up. Everyone will get the 6-month follow-up, a 12-month research follow-up, and then thereafter, it's annually. So a little busy in that first year, but then annual visits. In addition, at every single visit, we'll be collecting information on blood tests related to liver and inflammatory bowel disease activity. Every year, there'll be a FibroScan, as well as surveys on the quality of life. Regarding the imaging, as I mentioned, we're going to be enrolling 700 children. Approximately half of them, or 330, will undergo the specialized FRCP testing and MR elastography at 3 separate time points. Another bit of information on the biospecimens that we're collecting. So the white cells that we will collect at the baseline, as I mentioned, that's the most important time slot, because we're going to be able to compare what's happening in the peripheral blood, compare that to what was the FibroScan read, what were the biomarkers that we discovered, the levels of the biomarkers, so you can correlate what's going on using different modalities, and specifically getting at severity and pathogenesis of disease. So on the right is just an example. You can take those white cells and stain them for up to 50 different immune markers with 50 different colors, and tease out how different white cells are communicating and may contribute to disease. You can do the exact same thing with the liver tissue. And then I think this is one of just a few studies, probably nationwide, that is actually systematically collecting stool, and again, comparing what's happening with that microbiome with imaging and laboratories. This is information on who to contact if you go into clinicaltrials.gov. And then I also recommend that you take a look at our children website, where there's a lot of information, not only on the sites that are enrolling patients, but also educational information specific for patients and their families. That's it. Thank you, and I'll take questions.
Thank you so much, Cara. So we can open this panel up for some questions. If you don't want to go to a microphone, please write your question down. One of the amazing volunteers/runners will zip by and grab your question, and I can read it. I can start with a really naive question for you, Chris. So when you guys are doing the AASLD guidelines, how do those line up with the European guidelines?
That's a good question. So at the same time we were doing the EASL guide, AASLD guidelines, I should say, the European organization, EASL, was writing an update to their statements for PSC. And we actually did have some communication, particularly around the definitions of the strictures and the relevant stricture. We had a little bit of a disagreement. We couldn't quite get to the same definition, so there's a little bit of a difference, technical difference there. But other than that, the other recommendations are really pretty fully aligned.
Pretty similar.
Yeah.
All right, great. Go ahead.
Thanks. Dr. Lai, I really appreciated the nutrition advice, and it seems very simple, and I remember it like resonates with a lot of other advice, which seems like a good sign that it's probably true. The thing that confuses me is, if it's so simple, why isn't it easier to get good evidence, like scientific quality evidence, that that's actually helpful? And I guess relatedly, do you think we should be investing more energy into trying to get scientific level evidence that that diet or eating habits can help PSC?
That's such a great question. I think that the difficulty with nutrition science and getting good quality studies is that we don't eat nutrients. We don't eat individual substances. We eat food in combination. And it's very difficult to study the combination, because everybody has a different permutation of that combination. I will say that I didn't have time to present some of the evidence, but I did allude to that study looking at some of the eating strategies. So there are studies looking at ways to improve satiation, and increasingly we are studying, nutrition science is moving away from studying nutrients and actually studying behavior, because we are beginning to understand that really everybody knows what they're supposed to eat. It's just actually figuring out how to do it. And so I would say the studies are just now embracing that and evolving that, or evolving into those. We need more behavioral scientists, actually. I have struggled at finding people who go into that and want to study it as PhDs or as masters. And so right now there's a shortage of behavioral scientists, but hopefully that will change.
If I can just follow up on that, so Josh Korsnick is doing a randomized trial of diet in PSC. I don't know if Josh is here, if he wants to talk about that study. But anyways, I think there's an interest in that, and there are, there are changes that occur in bile acid metabolism with certain foods. We know that, and so the impact on PSC could be considerable. And we're doing some other studies looking at diets, reported dietary intake of certain nutrients, and how they might affect the microbiome, bile acid metabolism, as well as the disease itself. So I think there's a lot to learn there for sure.
Okay, here's a question potentially for both you and Gideon. What are the guidelines for monitoring recurrent PSC post-transplant?
So in terms of the guidance, we did not have any very specific monitoring, but really just reiterating that it should be investigated if there's change in liver tests. And it's a diagnosis that can be challenging to differentiate from rejection. So that's more where the guidance was rather than any specific monitoring. I don't know, maybe if the transplanters here comment on what their practices are.
Our practice has been partly out of interest for our patients, and from research, we are doing an annual MRI. We obviously do blood tests, and we have a low threshold for doing liver biopsies. I'm doing that partly because there are so few clinical trials for recurrent PSC, and it has such a big implication for patients that if I pick up recurrent PSC, then I'm willing to discuss with them off-label therapies.
And before I ask this next question, can you put the slide back up that had Dr. Mack's, the contact information for that study, please? I think people would like to grab the picture of that if possible. Okay, here's a question for you, Dr. Lai. Patients at healthy weight have less complications. When will doctors start recommending healthy weight management? And why are we not addressing patient nutrition, hydration, exercise, sleep, mental health, and emotional health habits?
Can I read the question?
Of
Echo.
course.
The echo up here is a little bit difficult. Okay, so doctors recommend. Oh yeah, I would love it if doctors would start recommending healthy weight management. And why are patients not, or why are we not addressing patient nutrition? It's interesting, if we look at the way that doctors are trained, at least when I went to medical school, this is how much information I received specifically on nutrition. And so actually it starts from the training of the clinician workforce, that nutrition is one of those topics that crosses across all diseases and all conditions, but unfortunately the field of medical education is very organ specific, and so it ends up being everybody's responsibility, and therefore in medical school sort of nobody's responsibility. And so that's part of the problem, is I think that there a lot of times that the clinicians I've talked to don't feel like they know exactly how to counsel their patients and what to tell them about. But this is part of the effort to change it, and I really thank the PSC partners for allowing me to give this lecture here today, so I can start giving sort of direct to patient education about this.
But Jen, one of the challenges for PSC IBD is the IBD. So although, I think healthy weight is really important, but actually epidemiologically our patients, yes, there are some who are overweight, but actually their struggles are different because of their active colitis and the consequences of their colitis, which then I think makes it very hard for their physicians to know how to give the really detailed advice, because for some patients, there's active colitis and low mass body mass is irrelevant. For other patients, because of their colitis symptoms, their diet is not as simple as, giving them what to eat because they don't tolerate certain things. So I think for our PSC IBDs, it's really hard because you're actually juggling not just the liver, you're juggling the colon as well, and then your whole health.
Totally. I mean, it's absolutely a fair point, but I think this really goes to show why it's so important that physicians, providers of care need to be educated on nutrition and speak to their patient because, for example, everything I said on the slide is not necessarily going to apply to you and your, if you have stricturing disease, you probably can't eat as much fiber. If you have, some people have to focus more on calorie intake because they just can't eat any food. And so it is important to have this conversation with your physician. And as patients, you can help start that conversation rather than waiting for the clinician to bring it up for you.
Hello, anyone on the panel. Is there any literature or studies in the pipeline that are contributed to the Camp Lejeune water poisoning and PSC, or anything on that for anyone? Camp Lejeune water poisoning happened at Marine Corps Base in North Carolina from 1959 to, 1959 to 1984, where a dry cleaning solution was leaking into the water table.
So I think that in terms of environmental impacts, in terms of risk of disease, I think there's definitely a lot to be studied there. And I have to say, you're not the first person that's come from a military background, I think, that's I've seen in clinic that has been concerned about exposures. And we just don't have the numbers to really say conclusively on a population basis about that. But it's all very possible. And I know, Gideon.
No, I think I agree. I mean, environment's clear. I mean, when I showed you the data yesterday, what's happening in Canada and the socioeconomics, I mean, that just implies, although there's lots of subtleties, that environment and diet environment is relevant. What I'd say is that we have to somehow find a way to invest in very long-term studies, which are very difficult because they pay off slowly. So in Canada, there's been a very long-term study looking at family members of people who've got Crohn's disease. So Ken Quattro and colleagues at University of Toronto have got a group of patients with Crohn's, but they've actually been studying their family members, okay, to try and pick them up before they develop Crohn's. But it's taken him 10 years, okay? And in that 10 years, a small number of the family members have developed Crohn's, but he's been measuring something in them every year from their blood and their stool, and he's picking up signs before they even present to their doctor. So I think your point is great, and I think environment is highly likely to be the biggest driving factor in PSC beyond genes. How we actually find out what that environmental trigger is actually quite a conundrum because it takes studies over 10 or 20 years to pick it up.
Thank you.
Cara, here's one for you. For children that are enrolled in the Prospective study but become adults during the time they participate, can they also enroll and participate in interventional clinical trials? So if they age out, I guess is what they're asking.
Yeah, we don't exclude patients if they're also going to be involved in a clinical trial. That would not be an exclusion criteria. They can be participating in both.
Okay. Yeah. Here's one probably for Chris or Gideon. You mentioned URSO in your talk. Do you not suggest high dose URSO for PSC? 1,000 milligrams daily.
Well, that's an easy one. 1,000 milligrams is not usually high dose. I mean, I think what Chris alluded to was really a great discussion that we've had for decades. But in the clinical trials, 28 to 30 milligrams per kilogram per day is associated with harm. But 28 to 30 milligrams per day is usually much more than 1,000 milligrams in my experience. 1,000 milligrams is usually more like 13 to 15 milligrams per kilogram and is a perfectly safe dose of UDCA. We could spend the whole weekend discussing whether or not it helps the patients, and Chris knows my opinions, it doesn't, and Chris can be more sort of diplomatic about it. But I mean, that's a safe dose and don't lose a second's sleep about taking it.
Okay, great, thanks. Dr. Lai, you ready? Any advantages to following a vegan diet?
Ooh, vegan diet. There are not a lot of studies, and certainly no studies in PSC. I actually, just in looking at the evidence and in general population and understanding the benefits of a vegan diet, I really do support my patients if they want to pursue it. However, vegan diets, individuals who follow vegan diets can very easily become deficient in certain nutrients, for example, vitamin B12. And also, I can tell you that a diet full of ultra-processed foods alone would be purely vegan. So there are lots of ways to do a vegan diet not well. And so I would recommend, if you have PSC and or IBD and you want to pursue a vegan diet, that you absolutely work with a registered dietitian to make sure that you are meeting your recommended nutrient needs, because there is just a stronger ability to fall short of nutrients, although there are known significant anti-inflammatory benefits of a vegan diet.
And just remember, around the world, the societies that live the longest are the ones that eat the least meat. So, I mean, epidemiologically, there's a lot of logic to it.
Just a minor comment there. It hasn't been published yet, and we're presenting at liver meetings. But we did do a small trial, not to advocate that someone should be a vegan at this point, but it was really, we took two groups. We randomized people to a high-protein diet, something called the specific carbohydrate diet, versus a low-protein, low-sulfur vegan diet. We were really looking at a microbial endpoint, what happens to the bacteria. But our surprise is that we did show about a 9 to 40% reduction in alkaline phosphatase. Again, whatever that might mean, but we did it with a particular hypothesis that confirmed that. And we can talk about that in more detail. So there may be a benefit. It's small numbers, so I'm not advocating that anyone do that at this point, but it's preliminary. There may be a role. It's not just vegan, though. It's also low protein, and there's limitations of how long you'd want to be on a low protein diet.
Yeah, I mean, the interesting thing is we published a paper, not me, I'm the journal editor, but we published a German group who put patients with PSC on a gluten-free diet. And although the gluten-free diet didn't affect the markers of liver biochemistry, not surprisingly, there was clear evidence that there was less fibrosis markers in the blood. So clearly it's something we need to explore in much greater detail. Can't give advice at the moment, but it clearly is highly relevant.
Great, we had a couple questions on gluten here from you guys, so I think Gideon has addressed that. I thought this was interesting. If you won't use biopsies as part of a diagnosis, how can you say it's okay to have multiple biopsies in a trial?
Because they're very different things. So as your clinician, what I'm trying to do is give you a clear, confirmed diagnosis of PSC. And I can do that based on taking a history, looking at your blood tests, and a good quality MRI. So in the immediate moment, I can give you very clear advice about what's going to happen to you because I'm confident what's wrong with you. And your clinician will know when that information is solid, and the clinician will then also know when it's a bit vague, and when it's a bit vague or there's some variance, they may want to do a liver biopsy. In clinical trials, the topic is totally different. I've taken patients who I know have PSC, and I want to give an intervention. I want to see whether the intervention makes something measurable different, so that I can then tell a whole group of patients that that new drug is going to make them live longer or feel better or have less scarring. In that context, liver biopsy just has a long track record of measuring liver scarring. It is by no means perfect, okay? But it has a longer track record of measuring liver fibrosis than some MRI technologies, than some blood tests. So in the hierarchy of how we make decisions about trying to make the most successful trials, at the present time, we have applied liver biopsy as an endpoint to see drug efficacy. Now, that said, we recognize it's actually got a huge variation. Even, people think that the pathologist looks down the biopsy and they just give you the answer. The truth is, if you take 10 pathologists and give them 10 biopsies, you get like 100 answers as to what they see, because it's a really, actually, amazingly difficult human skill to look down the microscope and measure inflammation and scarring. So we've learned the limitations of biopsies, which is why we think with new technologies we'll be able to do better, and it's because the new technology will be better than biopsies that we won't need them. So clinical care is one thing, and research is dovetailed with clinical care, but that's the reason why biopsies remain very important in research.
Thank you. Dr. Mack, can you talk more about the PROs that were decided on? The sleep is fascinating.
The patient-reported outcome, we don't have one for pediatrics, so step one is collect all the data on what are the most common symptoms, the things that the children and families are most concerned about. That's the goal of the early years of this study, and then eventually use that data to create a pediatric PRO. The adult PRO that many of you have probably used is, it was our understanding, is the only one that's validated for adults, and we want to see how well that reflects what's going on with the 16-year-old and up through the 25-year-olds that are in the study. And I've heard that it's got some issues for those that have taken it, but that's the best we had to work with for a validated PRO.
Okay, this question is for all of you, just it's yes or no. Can PSC, I'm just kidding. Can PSC patients drink alcohol? Cara, you start. Your patients, no.
Yes, no, yeah. And in teens, we just try to keep it really simple. It's just no, 100%. It's not going to be part of your life. You're going to have peer pressure. You can tell them you're allergic to alcohol. You can share with them your liver disease, whatever you want. But we try to keep it clean in the teens and just say it's not going to be part of your life, and no, because it can significantly worsen your liver disease.
I have to go next. That's no fair. She had out. This is off the record, but yes, in certain circumstances, but needs to be really tailored after very detailed information about your fibrosis stage, your trajectory of your disease.
Okay, you're welcome to all come to my clinic. The answer is yes. Just be sensible. You're all adults. And I mean, I take Cara's point, but I think all children drink at some point. So, you know, it's a really subtle discussion when you're talking to a teenager now in North America. I think the likelihood that there isn't alcohol at their parties is zero.
Oh, there is.
You know, so I think, and I think it's really hard to then, to have a meaningful conversation, you have to recognize reality as well as, you know, what you're actually recommending. But for my patients, the answer is yes. Just, you know, I always tell my patients, if you fall over and bang your head, you've drunk too much, okay? You know, but, you know, on balance, if you're sensible, you make lots of sensible decisions, in your life, okay? And, you know, PSCs are part of your life. It's not the only part.
So we had this discussion last night at the bar. And so, you know, early stage PSC, no cirrhosis, or I should say go the other way. If you have cirrhosis, no alcohol. I think that we would probably agree on that. The analogy I use in the clinic when I'm asked this is it's like asking me if you can speed on the highway, right? The posted speed limit's 65. You don't ask me if you can drive 70, 75, or even 80. I mean, you know there's a risk if you drive that fast. How much is that risk? Maybe not. Maybe something you're willing to accept, you know, but don't drive 100 miles an hour, right? That's sort of the guidance I would give. If you're early stage, moderate alcohol use is probably not harmful, but if you want to be really safe, drive 60, 65, that's fine. Don't drink.
Can I just put one more guardrail on our recommendation, though? There are two ways to answer this. One is sort of the medical safety for your PSC and your liver, but there are also transplant policies. If you are listed for transplant or being or sort of approaching the transplant evaluation stage, there are certain centers that will not allow you to drink a drop of alcohol. If you say you did and you knew you had PSC, that can be criteria for not being evaluated. That can be criteria for delisting and never being listed there again. So that I just want you to know that may not be because it's harmful to your liver, you know, a sip of champagne at New Year's or on your birthday, but it may be a policy decision, and so I want you to talk to your doctor and your transplant center if that applies to you.
I think that's probably a good place to end. We only have a few seconds left. There are a lot of questions remaining. I'm just going to hand these over to the person that they're directed at, and later we can give you their hotel room numbers. Welcome to find them later. and ask. I know that there's a couple of announcements also from.
Yes, go ahead,
from Ricky.
finish.
I think I'm done with my comedy routine.
Okay, this is a great place to end. So I just want to remind you of a couple things. One is if you will go out really quickly to the group photo at the grand staircase, and then we'll come back in for lunch. But we just made it a sort of a big change for dinner. So I know it was difficult for those of you yesterday who couldn't see us because you were behind those cabanas. So we're moving dinner to, it's called the Garden Terrace. So it's actually behind, if you go past the swimming pool, it's there. We'll have our volunteers showing you there. But a couple of things I wanted to tell you. It's a longer walk. So if some of you, if that's going to be difficult, they do have some wheelchairs. So if you would like a wheelchair, if you can just tell me sometime today, we'll know how many to have ready. And again, dinner's at 7, and we're going to have dinner first and then have our announcements and programs afterwards. Yes, the picture at 1, so if everybody will go right now, okay? To the stairs. To the stairs.